My name is Dr. Harold Bays, Medical Director and President of the Global Metabolic and Atherosclerosis Research Center. Welcome to this Cardiometabolic Health Congress post-discussion with regard to specific issues with regard to obesity. And very honored today to have some experts to talk a little bit about, have a discussion about obesity. And Carly, why don't you tell the people who you are and what you do?
Hey everyone, I'm happy to be back here. My name is Carly Burridge. I'm a PA and a fellow of the Obesity Medicine Association, and I am the owner of Gaining Health in Glen Ellen, Illinois.
Very good. Lou?
I'm Louis Aroni. I'm the Weill Professor of Metabolic Research at Weill Cornell Medical College in New York City. I'm the Director of the Comprehensive Weight Control Center there.
All right, so Lou, I want to start off with you with some perspective. What is your sense about how things have changed? Like, do you believe they have changed? And if they have changed, to what degree have they changed just in, say, the past 5 years?
Harold, I think there have been major changes over the past few years. Really, the biggest changes have been within the past 2 years. I think one big factor has been the relationship between obesity and worse outcomes in COVID-19 patients. The fact that it's very clear that people with obesity have worse outcomes is convincing everyone that obesity is a disease that can affect lifespan. At our hospital, the average person with obesity is 14 years younger than the average normal weight person. For people who are in the intensive care unit with COVID or who die from COVID. I mean, that is really shocking. Another big development has been the approval of the first new medication in a long time from the FDA, and that's a medicine known as semaglutide. And this is far more effective than anything we've had before. 15% average weight loss when combined with a diet and physical activity program. So we're really coming into a new era of medical treatment of obesity.
Well, I think that's exactly right. And so, Carly, let me throw it over to you here. I think a lot of people have heard about these changes. This is not coming as a surprise to many folks, but yet I think people still have questions. From your perspective, what would be like the most common questions that you receive either from patients or providers with regard to the new developments that we've had in obesity management?
Yeah, I think more and more people are recognizing obesity as a disease, but a lot of providers and patients still do not think about obesity treatment in the same way that we think about other chronic medical conditions. So one of the most common questions that I hear from patients and providers is how long do patients need to stay on medications if they're using a pharmacotherapy for the treatment of obesity? Because there's still this idea that patients take medications for a short period of time until they lose the weight and then we take them off of it. And we don't do this for any other chronic medical condition. So we really need to have a paradigm shift about the way we think about obesity as a chronic disease. And we need to explain this better to providers as well as patients so that they understand that for obesity management, this treatment needs to be chronic, just like we do for hypertension, diabetes, dyslipidemia, or any of the other chronic medical conditions that we treat. So first of all, that's the one question is how long? And then the second question is a lot of patients want to understand the risks of medications or surgery or other treatments, but what they often don't take into consideration is the risk of not treating the obesity.
Well, I think that's exactly right. Lou, I was going to ask this later on, but Carly's brought it up. I got to ask you. I mean, it's true. We put people on anti-diabetes medications, blood sugars go down. Nobody thinks to say, well, now that your blood sugar's down, we're going to stop your diabetes medication. Nobody thinks that. The same thing with blood pressure medications, same thing with dyslipidemia medications. What's your sense about why it is that people have this idea that if they're on an anti-obesity medication, once there is no further weight loss, that the decision is made to stop the anti-obesity medication? Where does it come from, and what do you do to talk to people about that?
Sure, Harold. This is really interesting question. And I think it comes from the fact that eating is a willful act, that you decide to eat. You decide when you're going to eat, or where you go to eat, what you're going to eat. But there's less control over how much you eat and what you eat than people think. In other words, there are physical factors that are going on in the background that influence all of that. And once you eat, food takes different metabolic pathways to make you feel like you've eaten. And what we're learning is that we can reproduce those medically. So we can produce mimics of some of the hormones that are produced when you eat food that make you feel like you've already eaten Thanksgiving dinner. I mean, that's a really effective way to reduce somebody's appetite. You would agree. Give them Thanksgiving dinner, they feel really full, they're going to eat almost nothing. Well, now we can give medication that mimics that. But the problem is that when you stop it, people are hungry again. And so what we need to do is have a major education program so that people understand. And we've used the exact analogies you pointed out. Same as diabetes, same as high blood pressure, same as high cholesterol. If you don't take your medicine, it's not going to work.
Well, I couldn't have said it better. That's exactly right. And I just wish more patients and maybe even some clinicians would get a better sense of that. Because I think there's this, I always call it the big lie. And the big lie is there's so many patients, they don't mean ill, but they are of the belief, if I could just get the weight off, I could keep it off. Mm-hmm. But yeah. Carly, let me ask you, is that always really true? So let's say, for example, just as a general standpoint, if a person has weight loss, is it necessarily the case that if they stop their anti-obesity drugs, they're going to maintain weight loss? And are there differences between patients? Say, for example, are there differences between men and women when it comes to weight management?
Yeah, I think something that we need to do a better job of educating providers as well as the public about is these metabolic and biologic adaptations that occur when somebody loses weight, right? So we now know a lot more about the science, and we know that when somebody loses weight, they get an increase in their hunger hormones and ghrelin and a decrease in satiety hormones. So this, of course, is going to stimulate an increase in appetite. And add to that some of the adaptive thermogenesis that can occur. So a slowing down of metabolic rate when we lose weight, because your body is trying to get you to regain weight. We are designed to be protected from weight loss and starvation, because for millions of years, that's what kept us alive. And so many people don't realize that these biologic adaptations occur and that they last for years after the weight is lost. And so medications and surgery and other treatments that we have available now that we understand the science better help to overcome some of those adaptations. And this is why these therapies need to be continued long term, because without them, your body's just going to go right back to defending your previous weight. And we're battling our own biology, which is why it's so difficult to lose weight and keep it off for many people without additional help. Now, we're all different. So this biologic adaptation doesn't occur the same way for every person. We know that there's a lot of individual differences when it comes to this. So we need to keep that in mind as well. And obesity is a very complex, heterogeneous disease. And so not the same thing is going to work for each individual. So we really do need to individualize treatment and monitor people individually.
And on top of that, it is just the pathophysiology. I think you would agree with that. There are also, social biases. As I mentioned before, the differences between men and women and such. Would you agree with that?
Absolutely. Yeah. Yes. We need to take all of those things into account. Dr. Aroni?
No, I agree completely. The average person is going to have a weight at the point of obesity. So it used to be at the point of overweight over 10 years ago. Now by 2030, the average weight of the average person in the United States is going to be a BMI of 30. That means that half the people in the country will have obesity. It's so commonplace, people don't even notice it anymore.
Right. And Lou, let me just follow up on that. It isn't just that obesity is a disease and it's variable among folks. I mean, there's specific populations in which obesity can just be devastating. Can you tell us a little bit about, say, for example, South Asians? I think that's a good example about, I think, a specific patient population that highlights the pathogenic potential of obesity. What's your sense about that?
South Asians are really interesting because they don't have to gain very much weight to develop the complications that we associate with obesity. And in that case, it's not so much the total body weight, but waist circumference. So what happens in people of South Asian descent is they have what some people would call a slight frame. And as they gain weight, they've lost a lot of the ability to gain fat superficially. So when they gain fat, the fat gain is inside the abdomen, and the visceral fat, which is the fat that really causes the damage. So as soon as they start gaining weight and their waist begins to expand because of this visceral fat accumulation, they begin to develop the complications like insulin resistance, diabetes, prediabetes, metabolic syndrome. And so when you go to South Asian cultures, you'll see that their guidelines are focused not so much on weight, but on waist circumference. I think that's a perfect example.
Yes. Okay. So Carly, I don't want to keep piling on because it just sounds like we're being all depressing here with all the challenges, but look, obesity, I mean, it is a disease. There are biases. There's special populations where, it's especially problematic, where there is exacerbation of the complications of the obesity. But you add to that the fact that some of these better medications that we have, some Dr. Ron just talking about, sometimes they're hard to get reimbursed. I mean, just a nuts and bolts clinician standpoint, do you have any tips you could give people to how it is they can better get these medications to their patients?
That's certainly one of the biggest challenges that we face in obesity management is insurance coverage. So I always encourage any providers and patients to look at the Treat and Reduce Obesity Act and to support this, to get involved with the Obesity Action Coalition and get involved with advocacy, because there are so many people who are affected by this chronic disease, and these types of medications and treatments should be covered for this, just like they're covered for so many other chronic medical conditions. And we know that there's over 236 medical complications of obesity. And when we treat obesity, everything else gets better. So it's just so crucial that some of these medications and these treatments are covered for our patients. So support the Treat and Reduce Obesity Act first and foremost. And then secondly, also is, we do have to use the tools that we have available to us. So if some of these medications are not covered, we do end up having to use off-label medications a lot of times and use the tools that are available to us to help our patients to the best of our ability. So definitely advocacy is super important, and then learning how to use the tools that we have available to us.
Well, Lou, then let me just springboard here off what you heard from Carly. For disclosure, I'm a clinical trialist. So I am not one that has advocated for the use of using different generic drugs and putting them together to equal a prescription medication. It's just not the way we do clinical research. But certainly a question we get is, let's just start with phentermine topiramate. Again, I mean, I've done the clinical trials with the combination agent, but some people ask, can you just use the generic topiramate with the generic phentermine and get the same thing? What's your sense about that?
Well, the fact is you can. It's a little bit more complicated, but you can prescribe generically. Physicians are allowed to prescribe generically when they think it's appropriate. So I would not stop someone from doing that. And in fact, we do it in our program as well. Is it better to take the brand? For some people, it is. It's easier to take. It's one pill once a day, taking the combination of phentermine topiramate. So it couldn't be easier. when you're taking the combination of two, the compliance may not be as good. In some cases, the side effect profile may actually be better when you split the two medications. But in general, we recommend on-label prescribing. But as Carly pointed out, and you pointed out, many of these medicines are not covered, which is a disgrace. We find that about 40 to 50% of patients who come to see us, and we are in New York City, a lot of our patients have commercial insurance, so we have pretty high coverage rates. But if a patient doesn't have coverage, it can be very, very expensive, and people are not going to take a chronically necessary medicine that way if it costs too much. So we utilize off-label prescribing until the time comes when the Treat and Reduce Obesity Act gets passed and these meds are covered. I mean, we at our center, we employ a full-time person to do prior authorizations. So we have a medical assistant whose only job is doing prior authorizations for the 9 physicians and 2 nurse practitioners. And we also utilize pharmacies that perform prior authorizations. So there are pharmacies that you can direct a prescription to who will do prior authorizations. So, those are a couple of things you can do to try to keep this going for the patients.
Right. Well, I mean, I think it's really, really good practical advice. So I'm going to ask this final question prior to wanting to get your, your ending thoughts. And that question is, a lot of times people ask, so let's say, for example, you have a person with the diabetes and you're trying to decide which sort of medication is going to be used, best to use in our patients with diabetes if they have the obesity. And I think this is where I think we're gravitating towards, and I think this would be consistent with the American Diabetes Association and other organizations and such. But if you have a patient with the obesity, if you've implemented appropriate nutrition and physical activity, and I happen to think metformin's a pretty good choice also. Afterwards, if they have congestive cardiomyopathy and they have the diabetes, I think a lot of people would gravitate towards the SGLT2 inhibitors. But do y'all see any reason why you would not want to put a patient on a GLP-1 receptor agonist like liraglutide or semaglutide if you have a patient with the diabetes and with the obesity? Can you conceive of a reason why that you would not want to make that choice, or that there might be a better choice, particularly given that in patients with diabetes mellitus, these medications have, a lot of them have cardiovascular disease outcomes benefits. I mean, let's start with you, Lou. I mean, what's your sense about that?
Yeah, of course. I mean, we pioneered using these things in combination. Even when people told us, no one's ever given these together. I mean, somebody's got to be first. And I guess it was us. And the results have been terrific. We've seen weight loss like we have not seen before. We've seen improved outcomes in people with type 2 diabetes like we haven't seen before. I think it's really a terrific combination for patients with diabetes. But again, the issue is coverage. So there are patients who don't get coverage for an SGLT2 or GLP-1, even though they have type 2 diabetes where they're clearly indicated. That's been the only barrier, I think, to prescribing these in every patient with diabetes.
And Carly?
Yeah, I mean, there's not much to add to that. Absolutely, these medications are very effective. I think anytime we're treating obesity, if we can kill 2 birds with 1 stone, and somebody has something like diabetes, we want to use medications that are going to help them with both their weight and their other medical conditions. So especially in the case of type 2 diabetes, the GLP-1 agonists are very, very helpful for diabetes and weight management.
And just so everybody's clear about what I was asking is, for the liraglutide and semaglutide, it's the higher doses that are approved for the obesity. And I wouldn't call them low doses, but the moderate doses that are approved for the diabetes mellitus. But my question was, for those situations where the drug for use of the obesity you can't get approved, if they already have the diabetes, then use it, and the diabetes, a similar drug, except for treatment of diabetes, if that is approved, then I think that's a pretty reasonable option in our patients with the obesity who have the diabetes. Okay, so with that, I would like to thank both of you. And just as kind of closing remarks, Carly, do you have any just final thoughts about give the clinicians out there some guidance, some practical guidance about how they can improve their management of the patients with the obesity?
Absolutely. I think I have 3 major points. One is diagnose it and schedule a follow-up appointment, because that's something where we're really seeing a lack of follow through with this. So diagnose obesity and make a follow-up appointment for them.
A follow-up specifically for obesity.
Specifically for obesity. So ask the patient permission, and if they say yes, schedule a follow-up specifically for obesity. Then next is have good intake forms. It takes a long time to get a history, to ask them about nutrition and physical activity and all these things. So have good intake forms so that you can gather a lot of this information before you even step into the room with the patient. And then third, use motivational interviewing. You don't have to have all the answers when you walk into the room. A lot of times, just by asking the right questions, the patient will become able to come up with a lot of the answers. And your job is to ask the right questions, to use the evidence-based tools that we have available to us, like pharmacotherapy, like bariatric surgery, and to be the accountability partner and the support for your patient.
Well, that's just outstanding, Carly. That's really great. Lou, can you add to that?
Yes, I can add
that?
one very important thing. Have
Okay.
the phone number of an obesity medicine specialist in
Okay.
your community who you could potentially refer the patient to. We find that a lot of the physicians in our community started out referring patients to us. When the patients came back, they got the idea of how this could be done. And so by referring patients to one of the 5,000 obesity medicine specialists and those who are trained, PAs, NPs who are trained, I think that can at least get the patient going and you can feel comfortable. We're now in the process of developing tools. We've developed a web-based platform which we are implementing through our entire healthcare system. It's called IntelliHealth, but the entire New York Presbyterian, Cornell, and Columbia system will have access to all the tools that we have in our center. So any doctor in our healthcare system will be able to treat obesity, will get a warning that the patient has obesity. So these are the kinds of things you can look forward to that will really help the treatment of obesity to move into the primary care setting.
And yeah, and before we close, there was a figure you threw out there. You kind of just flew right by it. Obesity, people that become diplomates of obesity medicine. This hasn't been there forever. It's just been in the past several years. How many other are there now? How many now?
There are now 5,000. Last year, there were 1,000 physicians passed the board, the American Board of Obesity Medicine's exam. And this is a huge advance in the field. And it's a minimum qualification. So it doesn't mean you're an expert, but it means that you have studied for 60 hours and passed a rigorous exam. And I look forward to the time when we see more and more physicians adding this, and others, PAs, NPs with their exams, adding this type of education to their qualifications, because anyone in internal medicine in any area realizes that the elephant in the room is that the patients have severe weight problems that are causing all the problems we're spending our time treating.
Yes. Okay. Well, guys, this was really great. This is really super. So, Carly and Lou, thank you so much. I think that covered a lot. That covered a lot of material there in just a very short period of time. And I want to thank you for your attendance. And again, this has been the Cardiometabolic Health Congress discussion about practicalities in obesity management.